Good morning, all. Good morning to viewers live on TTT. Good morning to ladies and gentlemen of the media. Welcome to the Ministry of Health this morning, where we are continuing our public education drive about mosquito-borne diseases, which we started on 10th of January 2024. When our first ad was put into the Express, Clean Your Surroundings. It then went into the Newsday on 10 January again, Clean Your Surroundings, and so on. Our first actual interview was actually done by Dr. Mark Dukaran on Wednesday, 1st May on TTT. Dr. Jeanine St. Bernard, who was here, was actually on Taj Radio Friday, 3rd May. And this just gives you an idea of how long now we have been preparing the citizenry about the perils of having mosquitoes in and around your surroundings. This morning, we have with us the Chief Medical Officer, who will be presenting an overview about dengue, locally, regionally, and globally. We also have to be followed after the CMO, Dr. Avery Hines, I think whom we all know. He is the Technical Director, Epidemiology, who will give you the current 2024 epidemiological stats and will give you some idea as to how stats are collected and disseminated. After Dr. Hines, we move straight on to Dr. Jeanine St. Bernard, who is the County Medical Officer of Health for County Caroni. One of the reasons we chose Dr. St. Bernard, as we have been saying over the past month, 3 of the counties that are recording the most amount of cases, one of them is County Caroni, the other one is Victoria and St. Patrick. Dr. St. Bernard will go into the signs and symptoms and the differentials of dengue and the role of the CMOH. And to round off the presentations will be Dr. Osafo Fraser, who is the Senior Medical Officer at the Insect Vector Control Division, who will speak about the most critical issue of source reduction and what the role of source reduction plays in managing mosquitoes, their population, and by extension, the effect on human health. So to get straight to it, I will now hand over to Dr. Roshan Parasram, the Chief Medical Officer, to do the overview on dengue.
Okay, thank you very much, Honorable Minister. Good morning to the members of the panel and members of the media and viewing and listening public. So we begin with, as Minister said, a dengue overview. So if I can go straight into my first slide. So if we look at dengue from a global and regional perspective, in 2023, a historic high of dengue cases was recorded worldwide, greater than 6.5 million cases and greater than 7,300 reported dengue-related deaths. Globally, as at April 30th, 2024, over 7.6 million dengue cases have already been reported to WHO in 24, with greater than 16,000 severe cases and greater than 3,000 deaths. In the recent years, the Americas have seen a substantial increase in dengue cases with over 7 million cases by the end of April 2024, surpassing the annual highs of 4.6 million cases in 2023. Dengue is one of the main reasons for medical visits in the region of the Americas, and the disease is endemic in over 100 countries, including Trinidad and Tobago. So dengue fever is endemic to Trinidad and Tobago. And if you look on the left-hand side of the screen, you will see the definition of endemic refers to the constant presence and or usual prevalence of a disease or infectious agent in a population within a geographic area. So on the right side of the screen, you will see a world map that shows on the top of it, if you look on the top, you'll see January isotherm. On the bottom, you'll see July isotherm. So that usually represents, in between those two of them, which starts at about 35 degrees north, going all the way down to 35 degrees south of the equator, you find that there's a high prevalence of the mosquito or the vector for dengue and other diseases like it. And therefore, we find Trinidad, of course, right in the middle of that. It lends itself to the explanation as to why dengue fever has been endemic to us and other countries in the region of the Americas and within those isotherms for many, many years. So this next graph gives you actually 43 years of data of suspected dengue cases since 1981 to 2023 in Trinidad and Tobago. So this data source is from the National Surveillance Unit, and I put it up to explain basically that Trinidad and Tobago has always been endemic for dengue. We have the vector in a fair degree of abundance because of the climate that I just showed in the previous slide, and it gives you, I won't go through every single year, but you see an increasing and decreasing pattern from year to year. There was a pretty high peak in 2002, 2003, where we had 6,311 cases. Again, in 2011, we're seeing 6,258. And what happens with dengue is it tends to go in a sort of 3 to 7 year cyclical pattern where you have surges and rises, surges and drops. Right now, from 2017, if you look at the right-hand side of the graph, to present, to 2023, and Dr. Hines will speak about 24, you're seeing that we enter one of those lulls. But for this year, it would seem that we have begun to go a little bit back up on the curve, and Dr. Hines will go into it later on. So in terms of identification, dengue fever is a mosquito-borne viral disease. The same mosquito transmits Zika and chikungunya viruses as well. This is an acute febrile illness. It's characterized by sudden onset and a fever of 2 to 7 days in most instances. Incubation period ranges from 3 to 14 days, commonly 4 to 7. And of course, the dengue viruses responsible for dengue fever include serotypes dengue 1, 2, 3, and 4. In the literature and research, there is talk of a dengue 5, but it hasn't been implicated in a lot of epidemics or endemic areas in the world. So we focus on dengue 1 to 4. In terms of our transmission, it's not transmitted through respiratory droplet like we see for COVID and flu-like illnesses. The main mode of transmission is via vectors. The primary vectors are the Aedes aegypti mosquito, which is, of course, endemic to Trinidad and Tobago and other parts of the Caribbean, and to a lesser extent, the Aedes albopictus mosquito. The albopictus is also known as the tiger mosquito, which is endemic to parts of Southeast Asia, but we have seen it in Trinidad as well. And the mosquito becomes infective 8 to 12 days after a blood meal and remains so for the life of the mosquito. The cycle on the right basically shows from the top, if you start on the top, virus multiplies in the mosquito, infected mosquitoes bites uninfected humans, virus replicates within the human, and then uninfected mosquito bites infected human, and the cycle goes around. What is termed the extrinsic incubation period, which is not the incubation period in humans, but in the mosquito itself, usually lasts anywhere from 8 to 12 days. Of course, if the temperature is hotter, it is thought that the extrinsic period shortens a little bit. So this is just to show you what I spoke about before, Aedes aegypti on the left and be able to recognize it. Aedes albopictus on the right. The Aedes aegypti mosquito is a day-biting species, which is important for persons to know. The increasing biting activity for 2 hours just after sunrise, so between, I would say, about 6 to 8, and just before sunset, so from around 4 to 5 going into about 6:30, you tend to see increased biting of those mosquitoes in the tropical regions, and the dengue viruses are maintained in human Aedes aegypti cycles. Also, other species within the genus of the Aedes, as I mentioned before, the Aedes albopictus, is less efficient of a vector in this part of the world, but not so in other parts of the world. Just to touch quickly on the cycle, mosquitoes need blood to produce eggs. Of course, only the female Aedes bites, which in terms of, because they have to get a blood meal in order to produce their eggs, and a mosquito eggs takes usually about 7 to 10 days to develop into adult. The life cycle is shown on the right, and Dr. Fraser will touch into the breeding sites when he goes into his presentation. So if we start on the eggs, we go to the larvae, and we go to the pupae. All three of those parts of this cycle require clean, clear, stagnant water to occur. Without clean, clear, stagnant water, this mosquito cycle is broken, and the number of adult females and adult mosquitoes will be diminished significantly. Right? In Trinidad and Tobago, if you're looking from a Ministry of Health perspective, the Regional Integrated Management Strategy for Dengue Prevention and Control in the Americas was elaborated by the Pan American Health Organization, and in Trinidad and Tobago has been utilized as our main tool for policy formulation and implementation since 2011, when we adopted this methodology to control the spread of dengue fever and other diseases, for example, Zika and chikungunya. If you look at the center of the management strategy, we're looking at 5 key areas, which is epidemiology. So we need to be able to define what we're seeing, and of course on the left of that we go to laboratory testing. Below that we of course focus on patient care, and Dr. St. Bernard will go into that today. Environmental management and insect vector management, Dr. Fraser will manage those 2 topics as well. And of course, within the circle, you can see on the left, operational research needs to happen. Combination for behavioral impact, also called COMBI, is again a tool that really teaches persons how to have not only communication, but communication to change their behaviors. And around the circle, if you look at it, we need advocacy, resource mobilization, partnership, monitoring, capacity building, and evaluation at all stages. My last slide is just to leave you with a few key messages in terms of preventative and control measures, which other speakers will go into detail. And our primary key messages from the ministry is source reduction strategies. If we reduce the sources, we can't have breeding, and then therefore there can't be increase in the prevalence of the disease. Recognition of clinical signs and seeking early medical attention and the importance of that. Personal protection, example, repellents, protective clothing, mosquito nets and/or insecticide-treated nets, window and door screens, as well as the last one, public education at the local community and the national level. So with that, I want to thank you for your attention.
Thank you, Dr. Parasram. Before we go to Dr. Hines, I want to reiterate one point that Dr. Parasram made, and something that I personally and everyone has been saying for the past 9 years. Because what I see coming out in the public domain is a misdirection about the role of water. The CMO said, clean, clear, stagnant water. What I see being portrayed in the media when you carry your stories is people are talking about dirty drains, mossy lakes and ponds. And the population is being led to believe that these are the sites where the Aedes aegypti lay their eggs. Those are not the sites. In the front page of a newspaper this morning, again, you see that misdirection. Let us be clear what we have been saying for the past 9 years. The Aedes aegypti, their primary place of breeding is clear, clean, stagnant water, which is primarily found in your homes and in your yards. It is not in those green ponds I see on TV in the night or in dirty drains. Yes, we must clean those. No argument there. But the population, when they are given the impression that the Aedes aegypti is in these dirty, stagnant drains, they are not focusing on the real place of breeding, which is in your homes, inside your homes with your vases, which you have your flowers in, your flower pots, your clogged gutterings, your water tanks. I am hoping that the live audience that I'm speaking to this morning, that I can re-emphasize again that message. And I ask us to be careful how we portray dirty clogged drains and mossy streams. These are not the primary breeding sites and breeding grounds of the Aedes aegypti. So I will now ask Dr. Hines, who is the Technical Director of the Epidemiology Division, to go into his presentation.
Thank you, Honorable Minister. Good morning, colleagues, members of the media, members of the viewing and listening public. My presentation today will be fairly brief. We're just going to update on the current statistics as it pertains to dengue for the year 2024 in Trinidad and Tobago. Quick update. So what we have here is a track of the laboratory confirmed dengue cases that have been reported to the system from January to June so far. We do note that the laboratory confirmation itself is done in some batches so that we get batch updates with a frequency of between 1 and 2 weeks, but that does not affect any of the clinical, vector control, or other management. The batch updates are really for our confirmatory purposes when we're reporting confirmed epidemiological cases of dengue. So this shows us that we've seen a steady increase from February all the way through to June so far in the number of confirmed cases each month. The next graph really shows the same information, but by epidemiologic week. So that you see it's not a linear or a straight line increase. There are undulations, variations, but there's an upward trend. And the upward trend is what we are attempting to disrupt by having the information shared on how to reduce the presence of the vector, which will then reduce transmission. So we're seeing this upward trend, and we're hoping that as the steps are taken within the households to reduce the presence of the vector and protective measures are taken by individuals, that we will see that trend level out and hopefully decrease. When we look at the types, CMO mentioned the 4 subtypes of dengue that exist. We do note that the types that we have been able to subtype, because subtyping depends on when in your illness you get the sample taken to be able to send it to the lab. If it's taken within the first week or so of symptoms, we can do subtyping via something called a PCR, polymerase chain reaction testing. But if not, then we can do antibody testing, and we won't get a subtype, but we'll know it's dengue. So of the cases that have been confirmed, 26% of them have been type 3. 3% have been type 2. The others that may have been taken later on in the trajectory of illness that weren't subtyped constitute the remaining about 71%, so not otherwise specified or subtyped. But this data tracks with the general regional pattern that has been seen, where type 3 seems to be predominant in this particular part of the world at this point in time. When we look at the geographic distribution of the cases, we do note, as Minister pointed out, that 3 counties at present are in the lead with respect to the number of cases diagnosed in those counties, and those are Victoria, St. Patrick, and Caroni, not in that order. And other locations so far have been the St. George counties, so St. George Central, East, and West. If you look at that on the map, we see the distribution of the confirmed cases that have been provided with addresses, and that's basically along that western side of the island so far. If we look at it from a county perspective, we do note, as we said, the darkened colors representing the higher numbers of cases. We have Victoria, Caroni, and then St. Patrick, St. George East, and then St. George Central and West. So that doesn't mean there are no cases in the other locations. There are going to be cases that either haven't come to the attention of the system yet, or that we weren't provided with an address for. So we are advocating that all persons in all counties take all of the necessary action to protect themselves and to clean up their in-house and around-house environments to reduce their risk of becoming infected. So that really wraps up my presentation for this morning. I'm going to turn you back over to the Minister.
Thank you. So Dr. Hines would have given you some update as to the distribution across the counties. We would have amended the yellow fever regulations to manage Zika back in 2016, where the fines for having unkept premises, those fines were increased from, I think, $500, CMO? Somewhere around $400 or $500, which was proven to be not a very good deterrent to 3005. And I did indicate earlier that we will be getting very active in one, issuing the citations and then giving persons 7 days to literally clean up their act. To date, we have issued 31 notices, and these property owners currently have 7 days to clean up their premises. The distribution is St. Andrew, St. David. 10 notices were given out. County Victoria, which is accounting, as Dr. Hines said, for one of the counties with the highest burden, 15 notices. St. Patrick, 2. Nariva Mayaro, 4. So a total of 31 notices have been given out. And we will be ramping up the inspections of properties by our public health inspectors and giving property owners a reasonable time to clean up their properties. If they don't, then we will apply the necessary legal fines. So that is where we are with helping people with our source reduction strategy. I will now ask Dr. Janine St. Bernard, the County Medical Officer of Health for County Caroni, to go into the signs and symptoms so people will know again what we have been telling you about the signs and symptoms and what the role of a County Medical Officer of Health is. Dr. St. Bernard.
Hello, good morning, and thank you, Minister. Good morning to Minister, good morning to my colleagues, and good morning to the media who are here, as well as to the viewing and listening public. This morning, as Minister has alluded, I will be, speaking to signs and symptoms of dengue, warning signs that will require immediate medical attention, dengue versus other flu-like illnesses, and then the role of the County Medical Officer of Health. So as we know, dengue has a wide spectrum of clinical presentations in terms of the kinds of symptoms that we can get, and the outcome and the evolution can be unpredictable. But most patients will actually have a self-limiting illness, which is non-severe, and some people may actually have no symptoms at all. But there are a small proportion of patients that will go on to develop severe disease. And I just wanted to make a point about cases. When we talk about dengue cases, remember, there are persons who have no symptoms and therefore will not be recorded because you are just literally asymptomatic. And then you have those who are mild and managing themselves at home. So what are the symptoms? The symptoms of dengue, right. You get flu-like symptoms which can last for 2 to 7 days, which CMO mentioned earlier, and the dengue will occur after the incubation period of 4 to 10 days after the bite from the infected mosquito. So what are the symptoms? When we look at these symptoms, you realize, well, many people may have dengue because many people have these symptoms. High fever is the first symptom that we look at, 40 degrees Celsius and above, and if it's accompanied by at least 2 of these following symptoms, we will consider dengue. Headaches, pain behind the eyes, nausea, vomiting, swollen glands, pain in the joints, the muscles, the bones, and sometimes even a rash. But of course, when you look at those symptoms, you think, but does that have to be dengue? Could that be something else? Well, yes. So in terms of differential diagnoses, it may be dengue, but it also may be flu. It could be leptospirosis, it could be yellow fever, it could be malaria. When it comes to the symptoms, which I mentioned earlier, if you have had dengue in the past and you get infected with another subtype, you get another episode of dengue, then you are at greater risk of developing severe dengue. And of course, severe dengue is the one we are concerned about because that's the one that leads to hospitalizations and, of course, worst case scenario, death, which we know is not often. When developing into severe dengue, the critical phase can take place around 3 to 7 days after the first sign of illness. And one of the things that even people, if you speak to people who have had dengue, they will tell you, you know, my fever actually went down, or my fever actually went away, but they were not actually necessarily recovering because they could have been then going on to developing warning signs. So we need to pay special attention to warning signs because if you have warning signs with dengue, you can then go on to develop severe dengue. What are the warning signs? Warning signs include severe abdominal pain, persistent vomiting. So you're vomiting, but it's not just one-off anymore. It is continuous. Breathing rapidly, bleeding manifestations such as the gums, or even bleeding from the nose or even elsewhere, fatigue, restlessness, blood in the vomit or even in the stool, feeling very thirsty, which tells us you are becoming dehydrated, having pale and cold skin, which tells us you might be going into shock, even feeling weak. Again, I want to emphasize, dengue with warning signs can go on to become severe dengue. And the emphasis this morning, and I plead with our population, please seek medical attention immediately if you experience any of the warning signs just mentioned. And in fact, at any point in your illness, if you feel unwell and you want to seek attention, do not delay. You can attend to the health centers, the district health facilities, you can come to hospital. And I also want to make a plug for our private physicians, because we know people in the public, sometimes you just go to your private GP. We are encouraging our private physicians to please share all your data, all suspected cases of dengue, share with the relevant county medical offices of health so that we can then activate and do what is required. In terms of diagnosis and treatment, there's no specific treatment for dengue, but the focus would be on treating pain symptoms. And for persons who've had dengue, they know sometimes they're at home and they would take acetaminophen, paracetamol, to manage their pain. We discourage the use of non-steroidal anti-inflammatory drugs such as ibuprofen and aspirin, because these can increase your risk of bleeding. And of course, if you increase your risk of bleeding, you're looking at severity, you're looking at hospital admission. For people with severe dengue, we ask you, please, report to a hospital, report to a facility, report to a physician so that we can treat you quickly. Now, some persons would have heard about immunity. Some people would say, you know, I heard that if you had dengue before, you can't get it again, so you should be fine. Now, remember, CMO alluded to 4 subtypes of dengue, dengue 1, 2, 3, and 4. So if after recovering from your first dengue infection, what will happen is in the 2 to 3 months following that, you are actually immune just for that short period against all of the subtypes. But thereafter, it is not long-term protection. After that short period, you can then become infected with another subtype. So having dengue in the past does not mean you will not get dengue again, because there are more than one subtypes. So you can then end up getting dengue again because you're experiencing another subtype. And again, I want to emphasize, if you've had dengue in the past and you get another subtype, your risk for severe dengue is now higher. So what are the other flu-like illnesses? When we look at symptoms, influenza-like illnesses versus dengue fever, they have similar symptoms. So fever, headache, fatigue, nausea, vomiting. Does that have to be dengue? No, remember we spoke about differential diagnoses earlier. But if you have an influenza-like illness that is influenza flu type, you would have cough, sore throat, runny nose, stuffy nose. Those kinds of symptoms you would not see with dengue. You would be experiencing that because it's a flu-like illness, right? So that's the same thing I'm saying here, which is fever, muscle and body aches, headaches, fatigue, and vomiting and diarrhea would be common to both. But if you're experiencing cough, sore throat, runny nose or stuffy nose, then we're more likely not to be dengue. And now for my final section, I'm going to look at the role of the County Medical Officer of Health. I am the County Medical Officer of Health for County Caroni. So what do we do in terms of assisting with the management of dengue? Apart from things like surveillance and so on, one of the critical roles that we're going to be playing in the fight against dengue would be our role with the public health inspectors. And our office, we are sending out the public health inspectors to assist with investigation of the dengue case. And once Insect Vector Control Division, which Dr. Fraser will speak to, has completed their spraying activities to kill the adult mosquitoes, then we go in. Because of course the implication, you don't want you going straight to the case where infected mosquitoes are still hanging around and then they're biting now all the officers who are going in to investigate. So killing the adult mosquitoes is first, and the public health inspectors who have powers of entry, we can then, as a team, we can go in, enter premises and conduct environmental inspections. And if there are any sources of mosquito breeding identified, the PHIs will be serving the notices, as Minister has also spoken about, to the occupier of the premises while recommending cleanup activities. These locations are then revisited by the public health inspectors in 7 days, and if at that time the remedial work has not been done, those persons will then be, or may be referred to the legal department of the Ministry of Health for further action. So that brings me to the end of my, oh, sorry, I do have one more. Okay, no. I wanted to just add the last thing, which was the private physicians. Again, please to share your data. Share whenever you have identified a suspected case, contact the relevant county medical officer of health so that we can begin work. So I do thank you for your attention. Thank you.
Thank you very much, Dr. St. Bernard. Our final presentation will be by Dr. Osafo Fraser, who is the Senior Specialist Medical Officer, Insect Vector Control Division. Dr. Fraser.
Okay, good morning. Thank you. Thank you very much, Minister. And good morning to my colleagues and the listening and viewing public. This morning, I do want to talk a little bit about what are the regular, more common breeding sites that we have around, and some of the practical strategies for dealing with them. And then at the very end, I'll talk a little bit about how the Insect Vector Control Division actually gets involved in dealing with dengue cases. This is an idea of the way in which the mosquito lays its eggs and the life cycle. And I put this picture up because it gives you an idea of how most of what happens in the life cycle of the mosquito takes place in water. And sometimes you don't need a lot of water. In fact, you can, as a small amount of water, as little as 5 mils, as a teaspoon of water. Once it's stagnant, preferably clean, the mosquito can do what needs to be done. And 3 of the 4 stages of the life cycle occur in water. As a result of that, it makes it very easy for us to be able to disrupt the entire life cycle of the mosquito, just by making sure we don't have any of these sources around. So this is a slide that shows some of the common sources of breeding. I'm going to go into some of these that we have here in Trinidad and Tobago. But barrels that hold water, old tires, plants, plant pots and plant plates, clogged drains and guttering, open and discarded containers. Those are some of the more common sources of breeding that we see when we go out into the communities. And let me put up some pictures that give you an idea of some of what we see. Many people still use water barrels for holding water for use, and water barrels and water tanks. And generally, once those are left open, the water remains stagnant. It's nice and clean for use, and it's an ideal environment for the Aedes aegypti to breed. So one of the things we recommend is you tightly cover those containers, or you can use a fine mesh to make sure that the mosquitoes do not get there. Because the Aedes aegypti mosquito actually lays the eggs on the sides of those containers, you do want to make sure that you're cleaning the sides of the barrels as well. At least once a week, you're getting in there, you're scrubbing the tops and the sides of those barrels to make sure that there are no eggs remaining. Old tires, that's a very common one that we see all over the place. And they're left there as a picture that shows you an ideal breeding environment. And the other thing about old tires is that you could transport the vector from one place to the next. If you have tires being transported from one site to another, the vector will actually go in those tires. And the recommendation really is to properly dispose of your tires. Some people use the tires for all kinds of things, and one of the things we recommend is making sure those tires are completely porous, there are holes right through them, so there's no opportunity for the collection of water. These are really, really common ones that we see a lot around, and this is the plant plate I was talking about earlier in that top picture, and that's a real popular source for breeding. And obviously the recommendation here is for you to empty those plant plates, clean and scrub them, because remember I did say the mosquito will lay the eggs on the sides of those containers, and those eggs will stick on there like glue and will not move even if you empty out the water. So you have to clean and scrub those plates and turn them down so they do not become an opportunity for any more laying of eggs. For those plants that are indoors, in the vases, the minister referred to them earlier on, And I know many people have those in the house. You want to change that water at least once a week. So you empty the water, but you also scrub the container like we talked about, right? Remember, you're trying to get the eggs off the sides of the particular container. So you scrub that container, soap and water, make sure it's nice and clean, change the water at least once a week, and that helps to take care of it. The picture below, nice pink, wonderful looking bromeliads, and I know many people have those. That's a, the minister's putting his hand up. Very nice looking plant, decorates nicely, but it is a reservoir for breeding. The bromelias is particular in that sense because the way in which it is shaped, it is, and that's where you water it from. You water from the top, and it holds the water. And if you're a bromeliad fan, you know you don't water your bromeliads too often because, all right, not into plants, okay. But if you do, the bromeliads are really nice for that. So once you put that water in, you're not watering again for another couple of days. And we know the life cycle of the mosquitoes between 7 to 10 days. So in a week, if you don't check back or do anything, you have breeding sites just from your one watering. So the advice on this is controversial, I know, because people like their bromeliads, and if I tell you no bromeliads, there will be an uproar. But if you can't do without them, fine. If you can't, the recommendation actually is to empty out those bromeliads at least once a week or wash them out at least once a week. It's the same principle. And in so doing, you disturb whatever eggs might have been laid, and you disrupt the cycle of the breeding. And then I just put this up because I wanted to make the point. This is a drain that's not outside. This is an inside drain in someone's yard. And we did talk a lot about drains earlier on, but what happens with these drains when they get clogged in your yard, after a while the debris settles and the top of the water becomes clear. And that is what allows the mosquitoes to come and breed. So it may start very murky, but after a while, because it's clogged, it's going nowhere, all the debris settles to the bottom and the clear water becomes a place for breeding. So you want to make sure you're cleaning your drains inside of your yard. The same applies to guttering in the roofs. And again, that's a once a week activity. All the containers that you are not using, just lying around the yard, and I put that up because that's a small cup, just a small amount of water, but an absolute ideal environment for breeding. And this is true for all kinds of old containers that you leave hanging around the yard. One of the things we say to people is, if once a week you walk around your environment and just check for sources of breeding, that's about a half-hour activity once a week. That will be enough to help deal with some of the source reduction issues that we're talking about. Finally, I just want to close a little bit about talking about what the Insect Vector Control Division does. And essentially, we follow the WHO's Integrated Vector Management Model for Vector Control. And this approach seeks to improve the efficacy, cost effectiveness, and the ecological soundness, and to make sure that our disease vector control is sustainable. And I underlined ecologically sound because whatever we do has to have a positive impact on the environment and should not be harmful to it. Our role includes identification and treatment of the vector breeding sites. So some of those photos I showed were actually examples of what we find when we go out into the communities looking around for vector breeding sites. We advise people what to do. We help to destroy some of the sites, and we also treat some of the sites when we go out. And then we also have a role in applying chemicals to kill adult mosquitoes, especially in areas where we know we have cases, or in areas where we have a lot of indication that there's a lot of breeding. And we do very rapid killing of mosquitoes using chemicals, but we also apply chemicals that allow for a more protracted effect against the adult mosquitoes. And so in so doing, we tackle both adult and the source. This is one final word I want to say on spraying, because we hear a lot about spraying. I know people, when you hear insect vector control, this is what comes to mind, this picture of a truck passing around spraying. And what we actually do is an ultra low volume of the substance that we use. and we spray that in an area. It's really good. It works well. It's beneficial for quick and effective treatment for adult mosquitoes in a large area. And we generally will do this if we have at least 2 cases in a quarter-mile radius in a particular area. We'll go and do spraying. And it is driven by evidence and science. Overspraying is a problem. Spraying every day, everywhere, all the time, increases mosquito resistance to the actual insecticide that we're using, which results in ineffective control when we do need to spray. So if we are always spraying and we do end up with the dengue case, if the mosquito is resistant and we go into that area and we try to use our ULV spraying, it will not work. There's also a negative impact on the environment and on those non-target organisms, so things like butterflies, bees, fish, some plants as well are negatively affected by constant spraying. And some adults are also affected by constantly being exposed to the particular chemical that is used. So that is the end of my presentation, and I hand you back over to the Minister.
Okay, so thank you all for your presentations. And at this point in time, we will open up the floor to questions from the media. Yeah.
Good morning, James Levin, Garden Media. I have several questions. Let's try again. James Levin, Garden Media. I'll start off with Dr. Fraser. I have a few questions, 3 questions for you and 2 questions for Dr. St. Bernard. I have some other questions for you.
Okay,
Minister.
so let's take 2, and then we'll give, and we'll go around.
That's what I was saying.
Suppose your 2 most important questions.
Well, then I'll go to Dr. St. Bernard since I have 2 for her. How many cases of severe dengue do we have or have we recorded so far? And you spoke of not using ibuprofen and I can't remember the other one. Basically Panadol, right? And you suggested steroids. Is prednisolone one of the things that we should use?
All right, so let me clarify. What we said is you can use regular paracetamol and you avoid the non-steroidals, ibuprofen and aspirin. So we do not recommend the use of steroids. In terms of pain management, which is the most basic form of management for dengue, it's just regular painkillers that are not the NSAIDs. Sorry, and to your first question, I don't have figures for, I can't speak to the figures for severe dengue. You mean specifically within County Caroni?
No. Well, I don't know if
Oh,
you
you
have
meant
for
for the
the whole of
country.
Trinidad or just county.
Okay, so at this point in time where all of the data coming in from the hospitals wouldn't have been collated, you don't get the regular updates on numbers of severe cases because what the people are doing in the hospital is treating the cases, not so much counting them. What we are doing at the Epidemiology Division is allowing the population to know that there are general increases in the transmission of dengue and letting you know clinically how to identify when you may be at risk for severe illness so that you go to the hospital and you get properly treated early. So the hospitals have not yet, at this point, complained of being overwhelmed by the cases, but they have noted increases in the presentations, but not with numbers that we can then transmit to you. I hope that partially answers the question, at least.
Okay, so could we go to another?
Well, it's the same question I was asking about the Panadols and whatnot, and the part B to that question was any home remedies you can suggest?
Well, basically, in terms of symptom relief, the main form of management would be the painkillers. So that's why I spoke to that. If it is somebody is getting dehydrated, we are asking that they present to a hospital and do not stay home to self-manage, things like that. So if it is you're experiencing any of the severe symptoms, thirst and all of that, I don't want to say rehydrate at home. It's better to go check. Let them say you are stable enough to return home, in which case the management at home would still be rest, of course, adequate nutrition, yes, hydration, and of course the pain relief.
Hello, Renessa Cutting, TV6 News. I've seen some members of the public asking about vaccination and whether or not that is available in Trinidad. And
Yeah, okay, so let's deal with the issue of vaccinations. I will start off and then I'll go to the Chief Medical Officer. The issue of vaccinations for dengue is controversial. Very, very controversial. I will direct you to read the report on what happened in the Philippines, where they used the vaccines. That's all I will say, and I will put you onto the CMO now.
So there are two types of vaccines that are in commercial use. So one vaccine is called Dengue. It's manufactured by Sanofi Pasteur, and the year that it was approved is 2015. The target for that particular one is ages 9 to 45. And the WHO recommendation that the vaccine be administered only to individuals who have a confirmed previous dengue infection due to the risk of, and this is the minister speaking to controversial, due to the risk of severe dengue in seronegative individuals. So just to try to explain that, and also, of course, in use in countries with very high burdens of dengue, which we haven't seen for quite a while. To try to interpret that statement, as Dr. St. Bernard would have said, when you have one infection with dengue, you have, let us say, type 1. The next season comes around, next rainy season, you have infection with another type. So you wouldn't be infected with type 1, you're infected with type 3. Those persons would have been previously infected, so they're not what we call seronegative, meaning they're seropositive. They had dengue before, their body has seen dengue virus, and they actually have some level of immunity towards it. That is what we call priming of the immune system. And what it does, it predisposes or increases your likelihood of getting severe dengue. Now, if someone is seronegative, and they're actually saying in their recommendation, WHO, that we should not use it in a seronegative individual as somebody who never had dengue. If we were to give it to somebody that didn't have dengue, it primes the immune system and increases the likelihood of severe dengue. So there is a significant risk there. The other vaccine is called Dengue, manufactured by a pharmaceutical company approved in the year Takeda. And that one is recommended for ages 4 to 16, again, in certain types, in certain epidemiological situations. And what is, in terms of the ministry's response, we have continued to collaborate with PAHO, as well as through our NITAG, which is our National Immunization Tag Group, Technical Advisory Group. We have been liaising to look at those particular issues that Minister raised and the recommendations for WHO to see if it can be used in our setting. So far, we haven't gone ahead and procured because of those controversial issues and those highly technical issues that we have to consider before we use it in our public. So it is under consideration at this point in time.
So basically, what are you saying? If we have to use those vaccines, we have to serotype everybody, which is simply not possible. And I would suggest you read the research coming out of the trial of these vaccines in Philippines. That will give you added information as to why we are not going that way at this point in time.
Okay. And as it pertains to public health inspectors gaining access to persons' properties, could you walk us through that process? Do you have to give consent? Can the inspectors access your property, whether or not you're at home? How does that go?
Right, so thank you for the question. So public health inspectors actually have powers of entry, which is something that has been granted to them based on their position. And so we don't, it's not like the public health inspectors will access your property in your absence. It's not like they're going to be breaking locks and coming in because, we're fighting dengue. No, this is done in collaboration with the persons who are residing at the premises. But they can, so it's not that they're going to access the property without you being present. And in a sense, because they have powers of entry, they can insist even while you are there. But I think if we needed to, like if we had a concern, a severe concern, I think we can even come with police if we needed to, right, to get some support in terms of entry. But it's something that we plan to work with the population, right? So it's not going to be some kind of aggressive approach, but public health inspectors specifically do have powers of entry to access or to gain access to a property in the presence of the owners, to then walk you through the environmental inspection, identify breeding sources, and so on.
Okay, so that's your two questions, Renessa. We'll come back to you. Sean.
Right, well, I would have to...
yeah, go ahead.
Dealing on curbing mosquito breeding on a macro level and micro level. So on a macro level, is your ministry have any liaison, even informally, with other ministries such as local government and works and transport, as regards clearing drains or bushy areas? Is there any sort of informal conversation instead of like, I mean, we don't want to insert a new level of bureaucracy in the thing. You know, I mean, we want people to do their jobs where they are, but there should also actually be conversations if needs be.
So two things. The answer to your question is yes. There is both a formal relationship between the county medical officers of health, IFECD, and the local corporations. So the answer is yes. However, your question is pointing again to the issue of cleaning dirty drains. And that is something I am steering the country and have been steering the country to understand that the main breeding sites are in your homes. And the media keeps tugging me and the population to focus on big drains and rivers. Those are not the preferred breeding sites. If Dr. Fraser, hold on, could I get my video, please? Let me show you what is happening in this country. This is a video of somebody in Santa Margarita who is probably a tire dealer, dumping tires in a private property. I want the public and the media to understand that the fight against dengue is primarily in receptacles that contain clear, stagnant water. Tires, gutterings, flower pot, saucers, the vases inside your homes, all those flower pots you have arrayed on your front porch, where you are 20 feet away from your kitchen, your bedroom. Please, ladies and gentlemen of the media, focus the country's attention on their responsibility for their surroundings. I don't know how else to say it. It is something we keep telling, but the media and the public always pulls us away to dirty drains. That is not the preferred breeding site of the Aedes aegypti. This one cap in your yard could contain up to 1,000 eggs. A tire, therefore, could contain 1 million eggs. They don't find a home in those mossy, green, dirty drains. Source reduction is primarily a domestic issue because the mosquito needs a human to bite to continue their life cycle. So again, I am urging all of us, and I'm pleading with the media, to focus the population on their homes, their gutterings, their flower pots, their vases, their water tanks, their barrels. Let me give you another practical example. Have you ever seen a house being built with a wall and they use the concrete blocks, right? And they put the concrete blocks up. And the top layer of the blocks are what? All the holes are there. 2,000 holes. Because they didn't put mortar to block off the holes. That is a breeding site. Multiply that by that concrete wall. Each block has 2 holes, and calculate how many blocks are around that house. And that affects you and your neighbors. The key to this is source reduction at the level of your yard and inside your home, Sean. Okay? Thank you.
Thanks. On the micro level, I was looking for what householders could do to stop mosquitoes biting, because, I mean, there are so many. What I found, only commercial remedies, I personally have problems with them. The cock set, I bought 3 different brands of cock set the other day, and nothing they're working. The mosquito is still coming. You're watching TV, they're still coming around you. The bug mat, the odomos, the citronella, for me personally, they all give me an allergy. As my nose start to run and I start to sniffle it out. So the question would be if there are any natural remedies, such as I saw something on internet, on YouTube, whatever, somebody putting cloves, sticking cloves into like a citrus fruit, whatever it was. Or there are certain types of plants, maybe lavender or something, the lady present may have a green finger, maybe, I don't know. But if there's any recommendation of these remedies, thank you.
Well, I could jump in, and anyone else who wants to add can add. As it relates to natural remedies, there are some plants that are helpful in the repelling of mosquitoes. There is some evidence that some plants are resistant to mosquitoes. You call some of them peppermint, rosemary, lavender. They actually smell better than the citronella, and people might prefer to have those around. So there are some plants that are good at repelling. Exactly how many plants you need, how long they will repel for, I don't think anybody really knows the research on that. But there is some benefit from using natural plants.
Okay, so let me just jump in here. The CMO said that these mosquitoes tend to bite mainly in the morning and dusk. What we can do as individuals, because where I live, I have the problem too. I don't go out in the yard without long pants. I don't go out in the yard without long sleeves. And if you have to spend a lot of time outside, simple common sense things, long pants, socks, long sleeves, and insect repellent to your hands and your faces. You know, just those simple common sense measures to decrease your chance of being bitten, right? Because to depend on plants, how many people have peppermint plants really? So it's not a viable alternative, right? Okay, so Sean got his 2 questions. Sunil.
Hi, good morning. Sunil Lala, TTT News. Minister, I'm not sure if the question is for Dr. Fraser or yourself, but there's been some media reports of citizens at home spraying chemicals. The chemical apparently, allegedly, is malathion without gears and equipment, without authorization. Is this something the ministry advises against?
Yeah, so I will take that question. That is dangerous. And it is something. Unfortunately, the issue of dengue, and I regret to have to say this, is currently being politicized. What you have are certain corporations and certain people seeing this as a political opportunity, as they did with COVID, and misleading the population. Remember when sunlight kills COVID? You remember, don't take the vaccine because you're a guinea pig. And these irresponsible people and some corporations, in an effort to gain political mileage, are encouraging their burgesses to risk their lives by playing cheap politics, by buying malathion and not giving them the protective gear. Dr. Fraser will have said and used the word ultra low volume. These things have to be titrated and calculated accurately to make sure that human health is not compromised. But what you have going on is a particular corporation in South Trinidad seeing this, led by their political directorate, to see this as a political opportunity. And they are putting their burgesses at risk. And what happens? You use it in the wrong concentration. You kill everything around you. You destroy your own ecosystem. 2, they are not wearing respirators. And I'm not talking about a mask. I'm talking about a respirator. I am seeing them not using gloves, skin exposed. Why are these corporations being so irresponsible? I don't advise it, and I am asking these irresponsible politicians to simply stop it and focus your activities on source reduction. Go into the people's yards and help them identify where the mosquitoes are breeding. In your pots, your vases, your gutterings. The money they are collecting to buy chemicals, buy nets instead and mesh for water tanks. Buy nets to sleep under. That is a much better use of resources, because overspraying, as we keep saying years now, results in two things. Those same families, 2 years from now, are going to spray, and you know what is going to happen? The mosquitoes will stand up there and laugh at you. I am being deadly serious, because they have built up resistance. You will destroy the ecosystem around your house. You will kill dragonflies. You will kill ladybugs. You will kill spiders. You will kill fish. You will kill birds and create an unknown ecological disaster. So I am asking for the cheap, dangerous politics to stop.
Yeah, and Dr. Fraser, just one question to you. In terms of the IVCD, I know you mentioned about spraying in particular when there are at least 2 cases in a quarter-mile radius, I believe you said. I note what you said about overspraying, but in terms of the IVCD, the Insect Vector Control Division, do you all have the necessary resources in terms of human resources, the equipment, and the fogging chemical to actually do this?
Yeah, so thank you for the question. Once there is a case of a reported case for suspected or confirmed, we will respond. And that response is done per county. Each county has an insect vector control division office, and that office is staffed with both people and personnel to respond to those cases. And we have been doing that since the very beginning, so yes.
Dr. Fraser, you mentioned this, but I'm not sure if you would be able to answer this question. You and the minister as well spoke of gutterings and barrels and these things being used. Have you all noticed, or is there a correlation between communities that lack pipe-borne water and dengue, those communities that need to use barrels and whatnot, and an increase in dengue?
So we wouldn't collate that type of data, but I see where you are trying to go. However, any receptacle that could contain clear, stagnant water, this cap could contain 1,000 eggs. If a community or a household doesn't have running water and you are depending on barrels, as I said, instead of the corporation spending money to gain media attention to spray, buy netting instead and cover the barrel. You know, it is so disheartening to see how this, like COVID, is being unnecessarily politicized. And I want to repeat, if we go back to Dr. Fraser's pictures, if you could get it quickly, the common breeding grounds. Yes, barrels, but cover your barrels with mesh. Get rid of your plant sources. Not just wash them out, get rid of them. Because unless you have the ability, those are the enemies. Please focus the country's attention on these things. This one cap, as I said, is 1,000 eggs. A plant pot saucer could be 1,000,000 eggs. So, whilst we like our plants, and when we have them on our porches, as I said, 20 feet away from your bedroom, that is where we need to focus on source reduction. So let us keep on focusing on source reduction.
And Minister, I can't recall who, but I remember reading someone asking for the modified mosquitoes to be used to combat dengue.
Yes.
Have you all, I see you already have a response prepared?
Yes. So there's a company called Oxitec that is pioneering the use of genetically modified mosquitoes in Florida, in Brazil? The short answer is no, it is not going to be introduced into Trinidad and Tobago. Why? One, there is not enough scientific data that shows that this works. Two, the risk of introducing an invasive species of an insect into your ecosystem is unknown. Three, the risk to human health if these mosquitoes, which are genetically modified, mutate, as insects tend to do, as we saw with COVID, things mutate. That is totally unknown. And I will quote from an article that came out of a study. The studies were not designed to test for disease transmission to humans. To do that, Oxitec will have to run massive controlled trials that will be difficult and expensive. It goes on. They're not going to be able to do a trial to show that it actually has a public health impact. I go on in that same review. Plus, disease transmission can happen even with very low population levels of Aedes aegypti. So reducing the mosquito population with Oxitec mosquitoes won't guarantee disease suppression anyway. What the article is saying, after I gave my assessment, is that even if you decrease the mosquito population with genetically modified mosquitoes to a low level, it does not stop the transmission of dengue from mosquitoes to humans. So I have given you the full rationale as to why we are not even considering it at this time until more scientific data comes in to show that the benefit, especially to human health, or the dangers to human health are not significant.
As it pertains to dengue type 3, how does it differ from the other serotypes? Is it more virulent? Is it more dangerous? And also, what are the risk factors for mortality? Because we did record 2 deaths. One was in a young person, and persons are a bit worried. So if you could kind of tell us what went on there.
Excellent question. So what are the medical practitioners?
So generally speaking, I would say, as I described before, you find that once you have one type followed by a second type, you have an increased risk of severe dengue. So either one of the, whatever the type may be, if it's type 3 followed by type 4, or the other way around, type 4 followed by type 3, the issue is the priming of the immune system to lead itself to severe dengue. Of course, we continue to look at the vulnerable populations, very similar to what we saw during COVID, the very young. With regards to this particular issue, you find if you haven't had an outbreak we haven't had a major increase in dengue for about 7 or 8 years, you tend to find the younger population, those under 7, tend to have not been exposed. So basically, they would have not had a previous infection. So if they're getting infected now, it will probably be their first time. Those beyond, let us say, 20 years of age would have had either 2 infections before, chances are. So the risky population you tend to find in terms of age is somewhere between that gap. So let us say 8 to 20 kind of age group, where you may have now getting a second infection. And that's the risky. And we saw it in other populations. There's research that suggests similar things happen in other parts of the Caribbean in the past, where you have that lull and then you're having an uptick. But generally speaking, those with weakened immune systems, as we described for COVID, those over the age of 65 tend to be at risk of any viral illness because of their vulnerable state. Pregnant women, we keep an eye on, and we're not talking about dengue alone. As we know, we're talking about dengue, Zika, chikungunya, and Zika, and the issues related to Zika as it relates to microcephaly and a lot of it. Pregnant women are considered a very vulnerable group in our population and around the world still for vector-borne disease. So those are the main sorts of groups we tend to pay attention to.
So Renessa, you raise a very important issue, and I just want to support what the CMO is saying. we want to be concerned like we did with COVID. And we said all this in all these media interviews we went on since January. The children with underdeveloped immune systems, they are at risk. And the elderly with comorbidities with compromised immune systems are at risk. So, again, source reduction, cover your body, long sleeves, long pants, socks, don't go outside without these, and insect repellents to your hands and your faces and necks. That is how we can protect ourselves.
Dr. St. Bernard, in terms of those who are asymptomatic and have dengue, how much at risk are they? Because I ask this because in terms of, I know it was said before that if you have dengue, it could go to from 0 to 100 in a matter of 24 hours in terms of that. But asymptomatic people, are they at risk?
Yes, so if it is, even though you've been asymptomatic, so you did not know you had it, you were still infected with the dengue virus, which means your immune system has been primed. So unfortunately, you don't have that history to share when you're being asked by your physician, did you have dengue before? And is this why we look, we're seeing warning signs? But you would still be at risk because if you've actually been infected, the downside is that you did not know you were infected because you were asymptomatic. And so we can't track you in the system and see because you had dengue before and this is your second exposure, that's why you're experiencing severe dengue. So we can't really, we don't know. We didn't know that you had it, but your immune system knows you had it. And so the response to the second infection, despite not having the knowledge of having the first one, that still means you can be at risk for severe dengue.
Understood, but in terms of asymptomatic people, let's say you had it before and you have it right now, but you're asymptomatic, are you at risk of?
Oh, that, yeah.
Well, I mean, you wouldn't know, right? So you wouldn't know that if you have no symptoms at all, you don't think you have any illness. But I do want the public to get, I don't want some miscommunication that is happening to continue. I just want to let everybody know, we don't want to feel, if I didn't have dengue before, I am not at risk of severe dengue, all right? You have to behave as if everyone is at risk of severe dengue. And we have to know, as Dr. St. Bernard listed the symptoms, we know the symptoms, and of course, if you're feeling unwell, you visit your healthcare practitioner as soon as possible. So we're not asking people to try to figure out whether you were infected or not. Look at the signs and symptoms that you have. If you're feeling unwell, you seek medical attention. Leave that up to the clinicians to figure out, but seek medical attention very soon so that we can look at other parameters. For example, we do a complete blood count, tells you the level of your platelets, for example, which is critical in dengue because you get lowering of your platelets in severe dengue. So once you seek medical attention, get to the point of care, we will do the other bits, try to figure out whether you have dengue before, which can be done by testing as well, and all the other clinical parameters that we look at to make sure that you're okay, all right?
Seymour, just one more question for me in terms of clarification. If, hypothetically, I get cold and flu symptoms right now, for dengue, you're saying not to use ibuprofen and those kind of drugs. Most people, when they get a flu, just a flu or the cold, they use certain tablets or certain medication. Is there a need not to use those ibuprofen or so on in case it becomes dengue?
So, I mean, the better bet, as Dr. St. Bernard said, is to start with the simple ones, right? The acetaminophen, and let us use those. If symptoms get severe enough to warrant higher level pain relief, generally speaking, you could seek medical attention and then you'll get the advice. In a setting where you have dengue being prevalent, it is always better to start with the simpler ones, which is not use the non-steroidal anti-inflammatories unless prescribed by a physician. At that point, they would have known whether there's an issue and they would prescribe it. But don't go ahead on your own and use those drugs unless you have clinical support to do so.
So now you raise a good question, and I want to come in here. The use of NSAIDs, non-steroidal anti-inflammatory, is something that if a layperson feels they have dengue, or if they have a fever, and you are going to a drugstore to buy something, speak to your pharmacist. A pharmacist can guide you accurately as to what is the best fever-reducing agent to use. If the population is unsure, please stick with the safe, tried, true, and tested paracetamol. It's 10 cents for one. You can get a card for $1. That is the best thing to do, and hydrate, but also seek medical attention. Okay.
Dr. St. Bernard had mentioned calling on private institutions to share their data for those who are going there for testing. I'm not sure, I believe Dr. Hines or probably the minister, do we have data from private institutions, the number of people who came and tested positive for dengue?
Okay. So the surveillance system comprises both the public and sentinel private physicians, and the private physicians that share the data shared through the county medical offices of health. So it's all subsumed within the data that comes into us. We wouldn't disaggregate to say, well, these came from private versus these came from public. But we are, as Dr. St. Bernard suggests, we are asking those who may not necessarily routinely share the data that they have to share with the CMOH, at least the county, at least the dengue-related cases, so that the appropriate actions can be taken, whether it is in investigation and intervention by vector control or other public health related actions.
And Minister, based on the citations that were issued, any of them were to public offices or all strictly private?
As far as I'm aware, these are all private. And you raise a good point again. I want to appeal to offices, places of worship, to also investigate your surroundings. Because in offices, we spend 8 to 10 hours a day. Many offices have plants. Many offices have sources that collect water. So I know maybe the OSH people, the safety, could just go floor by floor, make sure in these office situations we are not breeding mosquitoes in our indoor plants. Same thing for places of worship, where we go to a mosque, a mandir, a church, we spend a couple hours, make sure your surroundings in places of worship where we gather are also free of breeding sites. Vanessa, you look like you're eager.
Okay, so what is the confirmed number of cases to date, reported confirmed cases and hospitalizations, please, if you all have it? And also, how can members of the public report public breeding sites?
Okay, well, I can respond to the first bit of the question. So at this point, pending the next batch update from the laboratory, we're still at 229 confirmed cases and 2 confirmed deaths. We do not have hospitalization figures. We just know that hospitals have indicated that they're seeing more of these cases. We've taken note of that, and this is part of the reason that we are encouraging the population to take note of their symptoms, to be aware of the warning signs in particular, and to seek care when they are feeling unwell. With respect to the next question, I'm not sure who should take that. Would that be?
What was your question?
So generally for the reporting of breeding sites, whether public or private, the CMOH offices and Insect Vector Control Division, and all those numbers are listed on the Ministry of Health website, numbers and email addresses. Those will be the places that you forward those reports to, and then action will be taken.
Twice you said that the hospital is not counting the number of cases per se, right? Is that at some point in time you're going to start doing that, or no?
So that's not part of the routine data sent to the epidemiology division regarding dengue, but the important thing is not the numbers. The important thing is the characteristics of the cases, the sort of the clinical picture that is being seen, because that is the information that we then want to get back to the population so they know what symptoms to look out for, what symptoms are most commonly seen in the people that are coming to hospital, what symptoms they actually would have felt prior to being ill enough to be hospitalized. So when you're looking at that clinical picture, as we say. We look at that information and say, well, this is what's most commonly presenting. We see that people with, so they start off with severe abdominal pain that goes sideways from there. These are the things that we would then want to reinforce to the public that they look out for. So it's not so much the quantity, but it is the qualitative information, the clinical information that is really the most important coming out of those institutions.
Hi, Shilan Ramsubag from the Trinidad Express. So you all are saying that there's an increase in dengue cases. How equipped are the health centers and public health facilities to deal with this influx? Is it that you all are seeing an influx at those institutions?
So yeah, so I would say in different parts of the country, there are different levels of patients being seen. So as Minister said, and Dr. Hines presented in the Siparia, Victoria, and Caroni counties, for the last month or so, there has been an increase in dengue cases. I have spoken to all the chiefs of staff of the hospital, even up to this morning, and what the other institutions are saying is that there are not a large number of cases coming to them. Over the last 2 weeks, there would have been a slight increase at those areas, but the San Fernando Hospital and the Point Fortin Hospital are seeing a slightly more greater number of cases over the last 2 weeks or so. But that trend started, I would say, at the beginning of the rainy season, about 2 weeks after the rainy season actually took flight, which was middle of May into the beginning of June. And that over the last week or so, you have seen a slight uptick even beyond that increase. In terms of viral illnesses, inclusive of dengue, in terms of the proportion of cases coming from A&E, for example, in San Fernando, they would say it is not significant. Maybe 15% of the cases will be viral illness. The rest of them continue to be the normal chronic disease complications, for example, people coming in with cardiac disease, renal failure, complications of diabetes, hypertension, and the lot. So it is not overwhelming in terms of viral numbers. But they are seeing in the southern counties, you remember San Fernando General Hospital and Point Fortin take a lot of, almost 40% of the country in terms of people. And having the uptick in Caroni and Victoria and St. Patrick, you would expect that all those persons will be going, or most of them, to the San Fernando Hospital and the Point Fortin Hospital for treatment. So that's where you're seeing a bit of an increase. The other ones, including Tobago said this up to this morning, that they are not seeing a significant increase in that regard as well.
Minister, in terms of the reporting of cases, I think I heard you say it's more of an encouraging the private institutions to report these suspected or confirmed cases. Like COVID, when it was there, is there a need to actually mandate these institutions to report the cases?
So this is a different disease, and I don't think we should confuse it too much with COVID. Dengue, I showed 43 years of data. Dengue is endemic to Trinidad and Tobago, has been so for a long, long time. COVID was a novel disease. The case fatality was higher. It was spread from person to person very quickly. It was a public health emergency of international concern and became a pandemic. So you're looking at two different scales of things, and they're not to be confused. The categorization of the disease, therefore, is different from a public health sense. So mandating private physicians in that regard was essential to control. I don't think it is essential to control, but it is a good to have, for us to know exactly what the numbers are looking like from a national perspective, so we can see the full landscape of it. And of course, in terms of control, for vector control and CMOH to do their work effectively, they need to know where the cases are coming from. So we are encouraging them. As Dr. Hines said, sentinel physicians are already private physicians. So we have a relationship with private physicians, long-standing relationship where we give, there's those that give vaccines out on behalf of the ministry for childhood vaccination programs. They are called Sentinel, and they actually give us back data related to infectious disease. The ones outside of that remit are the ones we are encouraging as well to provide data. So if you have a suspected, we don't want you to wait on a blood test to confirm. We're just saying suspected, we will go ahead and do what we need to do environmentally to prevent spread. So it's just, at this point, is highly recommended to give us the data and encouraging them to reach out to the CMOH to do so. All right?
Okay. I think we have had a good session. That's it from the media for questions. I want to thank the media for coming out this morning. I want to thank TTT for carrying this broadcast live. It's a very important broadcast. And I just want to leave again with one message. And the simple message is focus on source reduction in your homes, inside your homes, around your homes, and with your neighbors, wherever there is clear, clean, standing, still water, which is the principal breeding sites for the Aedes aegypti. Let us focus on that and not get distracted by the noise that is misleading us. Focus on those areas of your house that contain clean, clear, standing water, and that will help us ride out this period that we are going through. Okay? Thank you all very much, ladies and gentlemen, for coming out, and I wish you a good weekend.